Thank you, Anna. Welcome, ladies and gentlemen. Welcome to Erasmus. As Anna said, my name is John Chang. I'm a Director for Research Enterprise Innovation. My background is in neonatology and pediatrician. I represent the clinical group dealing with the issue of type 2 diabetes. What I'm going to do is talk a bit about background of why I got involved in this particular project, and then go through some demonstration of some of the graphics you've already seen earlier on. These specifically the ones we concentrate on are the heat maps, the performance analytics, and predictive modeling that's been developed looking at diabetes specifically. What I want to do is paint you a bit of a picture of the background itself. What do we know about diabetes? First and foremost, it's no respecter of ages. Any person can be affected from the very young to the very old. Type 2 diabetes is different in the sense that it tends to more gravitate towards the elderly. So you've got a much more senior population, but that does not mean that it's just exclusively the elderly. What else do we know about diabetes? It is a growing problem and a very expensive problem. 382 million people in 2013 have been documented as having type 2 diabetes. It's an expensive problem. In America alone, $237 billion per year are direct costs of managing patients with diabetes. And if you look at the loss of productivity, sickness, and so on, they add another 90 billion in terms of indirect costs. What do we know about it? Certainly the common end state that we're all trying to work towards is reducing blood sugar, and that seems to be the tenet itself. Why do you want to do that? The issue is that if you do lower the blood sugar vis-a-vis the HbA1c levels, then you do see a lower risk complication rate itself. So if you look at the complications itself, by dropping it by 1%, not a huge amount, just 1%, you see a 43% reduction in ulcerations and amputations, a 37% reduction in renal failure, in blindness and visual impairment, 21% reduction in mortality rates, 14% reduction in cardiovascular complications, and 12% reduction in strokes itself. So there's an onus to try and remove some of the chronicity associated with this. However, the picture is not as simple as we paint. Just treating sugar's level isn't as straightforward. Why is that? You can see from the picture above me that the diabetic patient is not typical. You've got some that are rather obese, some that are very slender. It's no respecter of ethnicity. So you can see the different populations going through the world, that they can all be affected at different degrees. I'll give you some illustrative samples of patients we have to deal with. Mrs. G is 60-year-old. She's got 8 years of surrounding type 2 diabetes. HbA1 levels are high, 89, and she's BMI of 32, so it's clinically obese. She's needophobic. She's on maximized oral anti-hypoglycemic agents. On that basis, she's been well maintained. More specifically, she's got no evidence of any vascular complications per se. Contrast this with the other lady we've got to deal with in our clinic, Mrs. J. 55 years old, same type of BMI, 32, same type of history, 8 years of type 2 diabetes. Yet, she's got eye problems, she needs photocoagulation, she's got kidney problems, so GFR down in 20, she's heading towards dialysis and potential transplants, and she's moved on to a basal bolus insulin regime. Therefore, she's having different management and different complications, yet we're still calling it the same disease, type 2 diabetes. And I suppose in some respects, that's one of the reasons why we're here. Academia and science is a bit of a drawback. Why is it a bit of a drawback? Well, the Swedes beat us, I'm afraid. They used their national database in Scandinavia, managed to get a cohort of 15,000 patients in diabetic registry, of which there's just under 9,000 complete data files. And from that, in a clustering analysis, they came up with 5 types of diabetes. So it'd be interesting going forwards for research purposes. We're a bit disappointed because, as you can see, having 3 databases, we've already beaten in terms of numbers, 30,000. We're about a year and a half behind analysis, obviously ongoing. But it may possibly we'll be able to replicate the figures and confirm whether there are 5 or more types of diabetes per se. In terms of other issues, we know this is a big data conference, and as my colleague pointed out, diabetes is interesting because it's a little big as opposed to big data. Why is that? We have large volumes, so a variety of material, issues about veracity of data, but more significantly, we have significant value in terms of impact, both globally and economically. The databases that we've got available are various types, and again, you've heard today there's been issues about data in terms of merging it, and we have come across that in our own project. Diamond Database is a developed one by clinical experts in a tertiary centre. ProWellness is a commercial one you can buy off the shelf, that's developed by Epsom St Heliers, and you've got Croydon, which is an off-the-cuff, back-of-a-fact package job from Croydon. The process that we manage these data is very similar. Anonymisation using commercial product, upload data to the cloud, analyse our process results, and then visualising of the results itself. Why are we doing it? First and foremost is this. Right like Swedes, we want to generate some hypothesis what's going on. We may spot unexpected links amongst the data itself. And for that, we'll be using heat maps, combined data sets. This is an example of the heat map we got there. It's quick, it's dirty, but you can see the relationships graphically. So you can see very clearly the light shaded areas and dark shaded areas. And there's a correlation that may be there if we explore relationships. Outputs we've got down there's deaf, reading impairment, vision impairment. And you can see that for those situations, they don't all correspond to the same type of changes, which is interesting. What else can we do? We can use data sets to look at the medications, see side effect profiles, so-called pharmacovigilance. We also want to do other things as well. Predict responses and late side effects, predict cohorts, so that we can practice the issue of stratified medicine or personalised medicine discussed earlier today. Why is that an issue? Well, currently, when we manage patients, there's very much a suck it and see approach. You've got diabetes, we want low sugar, here's some new agents. Unfortunately, we're seeing that some patients do respond and some patients don't respond. And a suck it approach has a problem. You may give people who are non-responders therapy that doesn't work, actually give them more side effects. At the moment, we're looking at modelling to see whether that's indeed true or not. So what we intend to do is that get predictive modelling established, so we see the response to the third-line agents, and therefore minimise the side effect profile without incurring huge costs. And therefore we develop this stratified model of care for the patients. We also know that there are issues about the patient, phenotypic and laboratory variables that are going to be developed, and we won't use those to predict the hyper and hypo responders to SGLT inhibitors going forward. This is a crude first run of the patient profile we have for risk of death. When I first looked at it, we went, is our data really that bad? And unfortunately, when I checked it with the diabetologists, they did say that it was about a 5-year correlation mortality rate. That's about right. And that sort of scares us. So that's what we want to work on. So in summing it all up, the platform area was a combination of suitable databases, developing advanced analytics for both hypothesis generation and testing. Okay? What I want to do now is go through and show you some of those templates. This is me playing it just before you got here. And this is basically a visualization of the predictive index for blindness itself. You'll see that on the top here, you've got these various parameters which you can adjust. And when you do that, you can redraw the curve so that we can then see changes in the lipid profile. And if we adjust the issues of the blood pressure as well. And you update the graph. You then redraw the graph for you, and you can then see the shift of the graph backwards and forwards for the patients, which then allows you to be able to see what you can do to adjust this to see the outcomes. That's not the only visualization we can deal with. I mentioned to you earlier on we were doing heat maps, and this is another example of a heat map that we can draw from our data. Showing the renal impairments, vision impairment, renal impairment, death, and the colour coding that we saw earlier. We talked a little bit earlier too in the day about planning for trials, clinical trials. And again, if we want to do that, we can go back in visualization, This is a population map showing patient numbers. These are patients who've been predicted high risk or low risk of going blind or visually impaired. The dark colour bars are the ones that have actually gone and visually impaired, and those ones are the ones that are also visually impaired but low risk group. If you're planning a clinical trial, you can then pick this particular age range to decide on selecting those patients for your trial. Okay? That's demo over with on platform. Any questions, please? Stunned. Yeah.
Well, question. So, there's a lot of use of hypothesis generation tools, but I wanted a sense of how often do they pay off? I mean, how often are people chasing them and finding real, solid answers? I'll bring this up
I
because that's
think there's farmer in the room. Certainly, if we saw a graph, where do we go back to? If you see a graph or heat map, and you start seeing variables like this, and I was working in pharma, then I'll probably say, okay, this, yeah. Yeah. I would then look in this and say, I will look and see whether I can try a medicine that can combine the effects of lowering lipids or adjusting lipid profile with your effect on blood pressure to have an effect on renal impairment in diabetic patients. If I were trying to correlate some sort of response, then high density lipid profile will cut across the sphere in regards to death and visual impairment. But interesting enough, in our data so far to date, it does seem to have very little effect on renal impairment. So that's how we will see a hypothesis generation itself arise from this. I've only put 3 variables down, but potentially you could then try and look at other parameters as well. Stroke is in there in our data set. Okay, thank you.
This is oh, right, okay. Am I on the right one? No. Okay. Yes, here we are. Fantastic, thank you. Yes, I'm Dr. John Rumbold. I work as a Senior Research Fellow, or perhaps Official Underling might be the right title. So I'm going to talk a bit about the ESCO legal framework for big data research. So although I've been working with John on the diabetes case scenario as well, I've been looking at the ethical side. The legal side, of course, is Joss's domain, quite rightly, and you'll be hearing about that tomorrow. But the ethical side is quite interesting. We heard this morning from Deepak a few times this thing of trustworthiness. And that's very important, and that's something I'd like to emphasise as well. So one of the benefits of the AEGLE platform is we're developing it in the regulatory milieu of the EU. So there's a lot of robust protection for people, and we need to make sure that our platform is trustworthy and also that people trust us, which is slightly different because whether or not people trust us is dependent on their perceptions, and we can't always control that. We can control how trustworthy we are, though. So we're looking at a framework for ensuring compliance with legal and ethical norms, and as I say, our emphasis is on the ethical norms. So the fundamental ethical principles are well known for people that have studied, for example, the works of Beecham and Childress. So there's confidentiality, which all medical professionals are thoroughly familiar with from Hippocrates onwards. Respect for autonomy, justice, beneficence, these are the four principles. Avoidance of harm and risk, which is an interesting one because you might say, well, somebody's looking at my data, what's the possibility of harm? That will all depend on how you define harm. So one thing about trustworthiness is we want people to feel that their medical data has been used in a respectful way. Otherwise, you'll have issues with people withholding information from medical professionals. So there is a kind of diffuse type of harm that will happen if we don't respect people's autonomy. We've seen examples of this recently in the UK. So there was a governmental programme that was announced a few years ago called Care Data. And the idea was that they would use people's data, and the aims were very worthy, but they went about getting permission, although it wasn't really permission, in the wrong way. So they said, well, we'll assume we're all opted in unless you decide otherwise. And they sent out information, but this was sort of in amongst pizza menus and things like that. So a lot of people didn't even get the information because it wasn't kind of, coming in the right sort of way, and people just chucked it in the bin, thought it was another fast food company or something. So, we've got to make sure that we engage with people so they understand what we're doing with the data, and recognition of vulnerability as well. So how we deal with vulnerable people's data is also a very interesting issue. Big data has particular issues. So as we've come into the era of big data, how we handle data has had to be adjusted. And as I was discussing with earlier, the idea is that the General Data Protection Regulation is technology neutral, because technology is ever advancing and law has to try and catch up. And the particular issues you have with big data is that typically you're using data for a purpose other than the purpose it was gathered for. So it's a secondary use of data, so you have an issue there. Normal medical research, you get consent, so it's fine to deal with the data you've got. But here you're getting data that's been gathered for usually medical purposes. There's an issue with big data sets and with the advance in technology that people can be re-identified even when the data have been anonymized. There's also issues with profiling, when people are automatically assigned to particular statuses or treatments. You can infer new data, and that has its own issues. And then there's an issue of data categorization. So this is particularly pronounced with, a lot of us have activity trackers, or we have smartphones, which may have life and wellness, lifestyle and wellness applications on them. Are these medical data or not? Well, the answer from 2015 seems to be it depends on who's using them and what for. So if your doctor's having a look at how much alcohol you're drinking, that's probably medical. If it's Tesco's looking at how much alcohol you're drinking so they can send you vouchers, it probably isn't, hopefully. So one of the things we've been looking at is anonymization. So for me, I think there's an issue with anonymization in the law because there's one standard of anonymization across the board. You're either anonymized to this standard or you're not. And there's important contextual factors that I believe should actually affect what level of anonymization you have. So if you have a freedom of information request, and the information could go to anyone in the public, you don't know what use that person's going to put that data to. And so therefore there should be a different level of anonymization to when you're providing anonymous data to a clinical researcher in a controlled environment. This seems to make sense to me, but the legal framework doesn't seem to acknowledge this. So I think you have to have a look at both the different categories of data, because even within medical data you have different levels of sensitivity. The fact that I've gone to my GP for treating acne is rather different from if somebody had gone to the GP for a termination of pregnancy, which might be a very sensitive situation depending on the society. So, and again, who's dealing with your data? So one of the things we've been looking at is having a matrix that would look at the different circumstances. So you can have researchers who are either under professional duty of confidentiality because they're medics, and the law does recognise that there's people who are under this equivalent duty of confidentiality, certainly in the UK. People who are doing research in safe havens. So safe havens, the researchers are always under contractual duty of both confidentiality and also duty not to try and re-identify people. This comes back to the danger we mentioned earlier in big data, that when you have all these data sets, if you want to, you can often re-identify the person. You can do jigsaw re-identification. And again, the different levels of healthcare data and also particular circumstances. So if it's somebody famous who's having medical treatment and there's more data about them in the public domain, it's easier to work out if they're the person in a particular data set. And the Office for National Statistics recognises this. And for example, when they give open release data about residences and things like that, they know that if somebody famous is living in a particular locality, it'd be easier to work out they are in this data set. So this is one of the bits of work we've done. And the intention here is to guide research ethics committees and data access committees so that the categories of data and context affect the level of anonymisation recommended. This isn't a legal issue because the law is quite clear, there's just one standard, but we are arguing that there should in fact be some contextual differences in research ethics. The GDPR certainly makes reference to ethics, so the two ethics and law do intersect in this particular area. For example, recital 33. This states that generally for the GDPR you have to give specific, explicit consent to particular things. But in research, you might not need consent, and even where consent is required, it doesn't have to be to just a particular research project, data research, of course, GDPR. You can give consent to certain areas of scientific research. That's not further defined, but it's certainly not blanket consent. You can't just say, you can do with my medical data whatever you want. You'd have to say, well, you can look at perhaps cardiovascular disease or something like that. So well in keeping with recognised ethical standards for scientific research. So this clarifies this a bit more. So I think it probably doesn't make you can't have dynamic consent on this arrangement. I think that would be too broad. So dynamic consent is where you sort of assume you're able to carry on doing different research projects, but you keep people informed and they can withdraw consent. And consent to formal governance, which is where you would have your data in a data bank and you trust the people who run that data bank to only do acceptable projects. So that's probably not permitted under the GDPR. So we have research derogations in the GDPR, so we don't always need consent, and this is a very important point. There's several grounds for processing data. The consent exemption for sensitive data only applies to projects in the public interest, and this was mentioned earlier by Deepak as well, in regards to EMIS. So it has to be things that will that are in the public interest. Exactly how that's defined, again, isn't precisely prescribed, and it certainly wouldn't exclude projects that are funded by the pharmaceutical industry, because we know there's lots of research that would not take place without this funding. And clearly the development of new drugs, whilst obviously of commercial, financial benefit to the pharmaceutical industry, is also in the public good. But it might exclude things like actuarial research, for example. So, in terms of ethics, where research, data research is going on, you need either consent, or you need to anonymise the data, which takes it outside of data protection law, of course, or you can have authorisation. So this would be by research ethics committees or the equivalent. And this is the appropriate safeguards that the EU wants. The dividing line between direct patient care and research can be a bit tricky. And again, in the UK, we had a recent situation that's very relevant to AEGLE. So Google DeepMind had a whole load of data from the Royal Free NHS Trust. Lots of data about all the patients, as far as I can see, that had visited hospital. Google DeepMind were trying to develop software that would predict acute kidney injury. So this was the development. There's going to be product coming out of it. Their Caldecott Guardian, which is somebody in the UK who will decide whether or not you can use patient data without consent, said, no, that's fine, that's direct patient care, you can go ahead. the ICO disagreed for a very good reason, in my opinion. I mean, they were developing a product that had this very big data set of people who were very unlikely to have acute kidney injuries, you know, young, fit people who'd broken an arm or something like that. You know, all their data was going into this algorithm. So they were censured for not going through the appropriate purpose. I mean, they could have done this research. It wasn't a problem if they'd gone through the right channels, but they had, for some reason, decided this was just direct-to-patient care. And that's me, really. That's my description of some of the ethical problems that arise with big data research. And we've been doing a variety of publications here. And finally, just to add that you know, this presentation is about the use of the AEGLE platform. And if you wish to have a demo, you can go to this webpage. Any questions?
I was thinking in the big data arena, one of the things we want to do is to combine things sometimes, you know, clinical, biological. So if each part of data with this map has a different classification, let's say, some I can say from an ethical ethical legal viewpoint, some of them are more sensitive, some are less sensitive.
Yeah.
Then eventually, when we're going to combine, the problem will end up to the worst case, you know, to the most, because I...
Yes. Yeah, and then sometimes when you combine different data sets, because of the inferences you can make, it actually changes sensitivity of your data. So the classic example that's been reported is the teenage girl in America who was buying particular things from the supermarket, and they inferred that she was pregnant. So they sent her some offers for, you know, nappies or something to her home address. And the father got a bit upset. My daughter's not pregnant, you know, stop sending her stuff. It turned out she was pregnant. She hadn't told her dad. So there you've also got this issue of the inferences you make can be more sensitive than the data from which you inferred them as well. So it is a little bit tricky. I mean, it's all medical data. So it's all sensitive. So in one respect, it can all, but it's just a matter of some of it's a bit more sensitive than others. So you might need more precautions. Hopefully it shouldn't be too complicated.
So, very interesting. I really liked your idea about levels, but I just wanted some clarification. So in the U.S. we have something called de-identification, which isn't pure anonymization.
Yes.
You described some layers that almost sounded like. So could you elaborate on when you've had those different uses?
Yes. Yes, I know. From my discussions on that noble platform, Twitter, I know that, yes, in the US, there's a distinction between a de-identification and anonymization. I can never remember which way around it is. So you can just take away identifiers, but you haven't made it such that the person can't be traced. And then the issue is, how difficult do you have to make it for it to be legally anonymized? That's one thing. So, I know in America you've also got the hyper thing, which is specific to medical records as opposed to your general sort of data protection framework. So yeah, and in the EU it's all methods that are reasonably likely, which I find quite a weak test because it doesn't talk about somebody who's particularly motivated or who has knowledge that they've got from other sources. So somebody that's hacked into somewhere else and has got particular knowledge may be able to get hold of, combine that with some other details they've hacked. So it makes a lot of assumptions. So this is my worry. And so say if you've got somebody famous, go, no, in America they've had this situation where somebody released some medical records, but they knew a particular politician had been in town and had treatment on those particular days, so they were then able to actually work out what he'd had and things like that. So I think in the big data era, I think really regulators should be trying to catch up with this trend. And I mean, it is meant to be technologically neutral, the EU test, but I still find it's quite weak within that limit. It's reasonably likely. By whom? And that's somebody without special technical skills and without outside knowledge. And I think to apply that across the board, I think is potentially worrying.
I think it's almost impossible to be reliably totally.
Oh yeah, you can't rule that out. Yeah.
About people in the newspaper.
Yeah.
But what do you think about data use agreements as being sort of a protector against crazy stuff, especially if you can punish the user.
Well, exactly. When you've got the contractual duties of confidentiality, that's why I think you can allow the standards to be lesser. When you've got something that will say, if you misuse this data, then you'll be in breach of this. Yeah, I mean, as compared to when you've got an open data thing where you have to release it to the public. Yeah, absolutely. These arrangements are important to try and protect the public.
In Europe, have they made those levels at all? You were saying just one rule.
Not as far as I know, no, I don't think there is. It's just because, for example, in the UK, someone had done a particular study that was quite controversial, and they didn't want to release the data because they said, look, people, it was quite a small disease community, and their argument was, well, because people know other people in the disease community, if you release the data, they'll say, oh, but I know that person was at that hospital on that day. And the Information Commission officer said, well, no, you can't, as long as you provide anonymised data, we're not going to accept that argument because you can't tell us how the people would be re-identified. So they said, you've got to release the data. And I find that a bit problematic because elsewhere the Information Commissioner's office has said, we don't know what techniques will be used to re-identify people in the future. So they're implicitly admitting that the standard might not be adequate in the future, but you're going to release this data that could be used as techniques develop. So it doesn't seem to be the case that you can apply different standards. And like I said, with freedom of information requests, that's quite problematic because they'll just say as long as it's anonymised, you have to release it.
Sorry, just to continue on that question on the levels, because it would be of tremendous value if those levels are really made concrete. So have you taken that step that you identify this is what needs to be done in case of level 1, this is what it...
Yes, there are definitions in our paper about the levels of anonymity. It's in the process of being published. It's not been published yet, but it's going through its 6th revision, I think, so fingers crossed it will go through. But yes, we have made specific recommendations. So we've started from the hyper rule, and then we've kind of modified it, because the hyper rule has problems in that it doesn't deal with certain specific circumstances. The classic one in the literature is given being mayor of San Jose. There's only one mayor of San Jose, so if you don't screen out some information that's very specific, then you have problems. There is also a statistical standard for the hyper, but it seems to be very rarely used because nobody's exactly sure what the definition is. But yes, in our paper we do define further what the different levels of anonymisation could be and what information it would take out. So it's proportionate. And the main thing is to be proportionate because, as has been said, you can't, to make it impossible for people to be not re-identified, you just have to strip so much data out. We know this, and you don't want to do that. So it's trying to get a proportional standard of anonymisation. Right, thank you.